Good afternoon, everyone. Thank you all for joining the TxRx Echo brought to you by the Center for Substance Use Training and Telementoring, also known as CSTAT, by BWIL Texas in collaboration with the UT Health San Antonio Echo program. My name is Angela Riley, and I will be the facilitator for today's session. A few housekeeping items before we begin. Please continue introducing yourself in the chat. I see a lot of familiar names and new names, so thank you all for being here. Enter your full name, affiliation, and email so we know where you're joining from. Please do remember to stay muted unless you are speaking. We encourage using the chat and or the raise your hand feature throughout the session today to pose questions, share perspectives, and also share any resources you may have. We would love to have everyone with their cameras on as this does increase connection and engagement, though we do completely understand that some situations don't allow for the camera to be on. But if you're able to, we'd love to see everyone's lovely faces. If you're having connection issues, please privately chat Karen, our awesome Echo IT, for further assistance. As a note, these sessions are being recorded and they will be shared on our website for future reference. Therefore, to ensure privacy, no personal health information is allowed at any point throughout the session today. And this includes items such as names, addresses, birth dates, or other identifiable information. And let's see. Additionally, the slide presentation for today's session will also be uploaded and shared on our iEcho for future reference, and it will also be shared in our post-session communication email, so you'll have that information. At the end of the session, the Echo team will send out a post-session survey link. We kindly ask that you complete it as it provides us feedback on how to refine these sessions to better address your priorities. And finally, Echo is an all teach, all learn environment. We encourage everyone to participate in the conversation and share perspectives and raise any questions. And let us always make every effort to continue having this space that is respectful and safe for all of us to learn from one another. With that, we will start with some team introductions. I will begin with our lead specialist for today, Dr. Kowalczyk.
Hi, Alicia, Dr. Palchuk. I'm here at Baylor College of Medicine. I also work with Santa Maria Hospital, the Houston Recovery Center, and Harris Health here in Harris County.
Thanks, Dr. Kowalczyk. Dr. Shorter.
Hey everyone, I'm Daryl Shorter. I'm at the Menninger Clinic and I'm an associate professor of psychiatry at Baylor College of Medicine, and I'm also the director of our Addiction Psychiatry Fellowship. Thanks.
Thanks, Dr. Shorter. And playing a dual role today, we have our didactic and case presenter, Dr. Bone.
Hi, I'm Curtis Bone. I'm an assistant professor at UT Health San Antonio, part of the BWIL Institute and the Department of Family Medicine.
Thank you for being here, Dr. Bone. Thank you all that have introduced yourselves in the chat. Please keep those introductions coming. And with that, I'll pass the mic back to you, Dr. Bone. Once you're ready, please share your slides and take it away.
Okay, thanks so much. So I'm going to try to pull up the right screen here. And can you guys see okay?
That looks great.
Perfect. Let's see. So thrilled to be talking with you all today about recognizing and responding to medication side effects for people on medications for opioid use disorder. This is obviously a clinical interest of mine and also a research interest. I have no conflicts of interest to share, and yeah, there's our disclosures. What we hope to talk about today, so identify common side effects associated with medications for opioid disorder, describe appropriate treatment protocols for common MOUD-related side effects, and discuss treatment options for MOUD-related side effects. So that's the goal. This is essentially a paper that I share with all patients, providers, learners. It was written in 2012 by an oncologist, and it's 12 reasons, the top 12 reasons for considering buprenorphine as a frontline analgesic in the management of pain. And most of what this discussion today, presentation is, it's really just good news about buprenorphine. So the reasons why it's better than other opioids, including oxycodone, OxyContin, et cetera, for for management of pain is that people develop less tolerance to it. They develop less constipation. There's less, oh, for some reason that is, that's hidden. There's lower risk of overdose, obviously, low risk of cognitive dysfunction, immune suppression, and hypogonadism. So all in all, the gist of that is that it's a better opioid, has a better side effect profile than all their other opioids. Um, so when people ask, why would I use buprenorphine? I'm just trading one drug for another, or why should I switch from oxycodone to buprenorphine? What's the potential benefit? Whether someone has chronic pain or an opioid disorder, these are some core reasons. Um, what I'll do is talk a little bit about why that might be. So first, tolerance. So most opioids, heroin, oxycodone, OxyContin, um, they they have more complex downstream signaling than buprenorphine. So higher levels of phosphorylation of various pathways, and the end result of that is something called beta arrestin recruitment, which results in endocytosis of the receptors. And when endocytosis occurs, that means that receptor disappears. And so the number of mu receptors reduces, which means that you need higher levels of drug to get the same level of analgesia. So that's what leads to tolerance. So buprenorphine, because of its specific activity at that mu opioid receptor, has less of that. So it has less of there's less neurobiological adaptation that occurs as a result. So that's key. There are lower levels of constipation, overdose, and cognitive dysfunction because of buprenorphine's unique activity also at the delta and kappa opioid receptors. So um, it's an antagonist at the delta and kappa receptors, while heroin, oxycodone, OxyContin, methadone are full agonists. And so you have that cumulative effect of mu opioid receptor activity plus the delta plus the kappa with our full agonists. And you have this partial agonist, partial antagonist activity of buprenorphine, which reduces constipation, respiratory depression. Um, it also reduces the amount of euphoria someone might experience. Um, and that reduced level of euphoria means that there's less reinforcement, less activity in the reward pathway, and so lower likelihood for cravings as a result. The NOP signaling that's similar in that it's going to activity there, agonist effect there is going to limit substance abuse intolerance for similar reasons. So that's sort of a space that people are looking at for novel drugs to kind of piggyback off the success that buprenorphine's had. So in addition to lower levels of constipation, like I said, at higher levels of buprenorphine, you have higher levels of activity at the delta and kappa receptors, and that's what provides that protection from overdose and also from sedation, which is going to improve cognitive function. And that's the thing that I hear most often from people that transition from full agonists, oxycodone, oxycontin, over to buprenorphine, is that they're more mentally aware, they have better energy. So some nice features there. Immune suppression is a side effect of opioids. If that occurs by dysregulation at the HPA, the hypothalamic pituitary adrenal axis, which results in release of ACTH, which stimulates cortisol. So in this situation, you're going to have lower levels of macrophage beta lymphocyte activity for people that are on opioids. So who that might be relevant for? Patients with cancer, patients with recurrent infections. They're going to have better wound healing, lower risk of infection, et cetera, with buprenorphine compared to other opioids. And then at the hypothalamus, so we have the hypothalamic pituitary adrenal axis and also the hypothalamic pituitary gonadal axis and hypogonadism that can be a side effect of opioids. Again, buprenorphine shown to have lower levels of dysregulation at this axis as well, so lower risk of hypogonadism. And so some of this, so the medication side effects, tolerance, constipation, overdose, cognitive function, immune suppression, hypogonadism. How do we look for these things? Um, so if someone is on buprenorphine, they tell me that they've developed tolerance, what I will generally do is look for an alternative explanation because that shouldn't occur. But people will sometimes say, well, I don't have as much energy as I did before, or I feel, body aches, or my nose is running, or I feel like I'm in withdrawal. That can be from lots of different things. So that can be from a dysregulated sleep cycle. It can be from a viral infection, but often there's some other explanation. It can be from other substance use. So if someone is using other opioids, then their tolerance can be driven up. And so when you hear that, you want to look for an alternative explanation besides the buprenorphine. So people generally can stay on the same dose for years and years without developing tolerance. And that's where urine drug screen comes in. As far as screening for constipations, this is something we should do. Candidates should do at every visit, ask about hard stools, straining, etc. Constipation is not benign. It can result in painful hemorrhoids. It can result also in something called diverticuli, little, tears in the gastric mucosa that can get infected, lead to severe infections, potential surgical need. So I talk to people about bowel pressure. I tell them, a lot of people think about blood pressure. I think about bowel pressure, and we want to make sure that your intestines, that are sort of these soft tubes, are functioning in a low pressure system. And so things that we can do to address constipation when we encounter it, hydration, fiber, colace, Miralax, Senna. Methanol is a GI opioid antagonist that's specific for opioid-induced constipation, very effective. It's just costly. And then you can adjust dose if needed to address constipation. That's a situation where you have to really think about benefits and risks, and if the potential benefit of a dose reduction versus the risks there. And then the other nice thing about, overdose risk with opioids obviously is there. With buprenorphine, you cannot overdose unless you combine it with other opioids, with alcohol or with benzos. And so we can screen for that risk by using urine drug screens. We can look at the PDMP to look for comorbid prescribing of other controlled substances like benzodiazepines. A PEth test can tell us about alcohol use. That's fairly remote and going to be a lot more sensitive than blood alcohol test. I'm sorry, breath alcohol concentration test. So those are a few tools that we have. If we do encounter it, then we want to think about harm reduction opportunities, motivational interviewing, potential, I should really say medication adjustment to address underlying issues. Sometimes if someone's using heroin while they're on buprenorphine, they may actually need an increase in their dose of medication. And then education is obviously critical for people. Naloxone can be on that list of potential interventions to prevent overdose. With methadone, for those that are working in methadone programs, obviously the same things exist. It's given under it's directly observed therapy, so that helps us limit risk, and all the same things apply. Cognitive dysfunction, immune suppression. There's no real protocol or established test for these things. If it's obvious that someone is experiencing cognitive dysfunction or immune suppression, looking for potential root causes. Is this opioid related? Is there another substance involved? And then hypogonadism. So this is a symptom triggered evaluation, and the treatment would be hormone suppression. So I mentioned to folks that there was a survey that would use to kind of inform this talk, and most people said they weren't super familiar with hypogonadism. So I'm going to take a few minutes to talk about that more specifically. So here's a quote from a patient. I'm just tired. I wake up in the morning. I feel like I'm more tired than when I went to bed. My wife, she doesn't like that, and it's hard to go to work. So this is patient quote. And that is one symptom of hypogonadism: decreased energy, vitality, well-being, and motivation, decreased work performance, decreased mood, feeling sad or blue, impaired cognition, which we saw in that previous slide as a side effect of opioids, sleepiness. And then people can also experience weight gain, change in testicle size, change in hair growth, gynecomastia, low sex drive, and other forms of sexual dysfunction, anemia, change in bone mineral density, and change in muscle mass. So again, the good news is that buprenorphine does this less than other opioids, and some studies suggest that it doesn't actually have an impact on the HPG axis, although um, the the literature on that you could argue is the sample sizes aren't huge in a lot of those studies. So if we do want to evaluate and treat this, we do see these symptoms. So in women, they may experience amenorrhea. We can screen with estrogen levels. The Society of Endocrinology has agreed that an estrogen level less than 200 is diagnostic along with several months of amenorrhea, or an ultrasound that shows an endometrium less than 4 millimeters. Yeah, and the treatment is estrogen replacement for them. For men, there's a very clear kind of evaluation protocol where if there are symptoms that were just described, we can get a testosterone level. It should be checked in the morning. If it's normal, fine. If not, then you want to repeat that testosterone level along with LH, FSH, PSA, hematocrits, um, and and then based on what the LH level is, you might consider starting testosterone replacement therapy or additional evaluation. Um, but there is a really clear, evaluation and treatment protocol for this. There was recently an article in the New England Journal of Medicine that described some kind of myths, misperceptions related to TRT. There were some studies that were done in sort of the 2015 that suggested increased risk of cardiovascular events with TRT. And more recent research has shown that there may have been some statistical flaws in that study, and the preponderance of evidence suggests that there's actually not an increased risk of cardiovascular events. There's actually not an increased risk of prostate cancer. That and in many situations, the benefits outweigh the risks for treatment. So the preliminary objectives today identify common side effects associated with MOUD, appropriate screening protocols for MOUD-related side effects and treatment options. And these are them. I think we all run into tolerance, constipation, risk of overdose. We're all very familiar with those things. The things that people seem to be less familiar with based on research, cognitive dysfunction, immune suppression, hypogonadism. Buprenorphine is better with all of these side effects than other opioids. And I think as we raise awareness among patients, I think it helps just with that conversation around motivation to get people on buprenorphine, which is again just a better medication, in my opinion, than other opioids for treatment of pain, and obviously better for the body than heroin, fentanyl. So these are my references.
Excellent. Thank you so much, Dr. Bone. I'd like to open up the floor for any questions from either our hub team or our audience for Dr. Bone and his presentation. Valerie, I see you posed a question. I invite you to unmute and can you ask your question, please?
Yeah, sorry. I was just wondering because patients that we see that are on buprenorphine will usually experience tooth decay after being on it for a while. What would you suggest for patients that are taking it and kind of doing well with it, but their teeth are kind of bothering them with the medication?
Yeah, so oral health is a big problem in our population. There's lots of reasons why people with opioid use disorder might develop oral health issues. Well, a couple that we just mentioned, right? Immune suppression issues, um, changes in bone health. Teeth are bones. Um, so generally, what I tell patients is we know opioids impact bone density. Like heroin, for example. Buprenorphine seems to do that less. As far as the potential, some people think that the films may be specifically affecting sort of acidity and tooth enamel. So injectable buprenorphine is an option, but I've had plenty of patients that have been on buprenorphine for decades that don't have oral health issues. So I really kind of talk about general oral health, other things that could be impacting that, for example, carbonated beverages, um, and then just counsel around, optimizing all of those other variables. And then, yeah, if they feel like that it's a big concern, the injectable buprenorphine would be another option. And then obviously naltrexone is an option for people as well.
Thanks for your question, Valerie. I do see another question. Any advice on what to do for patients who can't tolerate buprenorphine because of the taste?
Yeah, some people, I guess a lot of people have that experience. So you can try different formulations. Zubsolv, which I haven't heard about in quite a while, it seems to have a better taste than Suboxone. And some people prefer the tablets for that reason compared to the films. So it's sort of just very person specific. Um, yeah, I don't have a whole lot beyond that. Trying different formulations and yeah, that's sort of what I do. And then the injectable is also an option for those who can afford it.
I've had experience, a lot of patients are still thinking that they have to swallow what remains, their spittle that remains, and oral secretions after the Suboxone or buprenorphine product has dissolved sublingually. And that sometimes increases their displeasure with the dosing. And so, again, exploring how they're taking it and letting them know they're not getting extra dose because they swallow the remaining spittle once it's fully dissolved, and then being able to be in a place where they can quickly rinse out their mouth, water, or beverage of choice minus alcohol.
Thanks for
Um,
that, Kowalczyk. I'm
yes.
seeing a question on here about dosing suggestions when people to rotate to buprenorphine for treatment of pain for folks that are opioid naive and tolerant. Um, and then someone's asking about protocols on how to do that. So there are microinduction protocols out there that a lot of people have had success with if someone can't tolerate the withdrawal period because of pain. So that's an option. Um, the the ratio that I've had the most success with from converting people to full agonist opioids to buprenorphine is 10 to 1. So which I haven't seen published anywhere. I've seen 7 to 30, but that's how I was trained through my fellowship was use a 10 to 1 ratio, and I've just had a lot of success with that. So that's what I do. So if someone's on 120 morphine mill equivalents, then I'm targeting at about 12 milligrams of buprenorphine. Um, for people that are opioid naive, so I would never start someone off on, 120 or 160 morphine mill equivalents for treatment of pain. I would probably use the Butrans patches, the Bup patches. They're more like one morphine mill equivalent to like five morphine mill equivalents throughout 24 hours. Um, so that's where I begin. And I have a very low threshold to transition someone from full agonist to buprenorphine, a very high threshold or a much higher threshold to start someone on an opioid that is opioid naive, because it is a commitment. They will experience, they'll develop opioid dependence, and there are side effects that come along with opioids that we just talked about, immune suppression, et cetera. And so, yeah, so I do have a reasonable threshold to start someone. Those side effects do seem to be dose dependent, and like I said, buprenorphine is clearly better than other options. So yeah, I would start with the Butrans patch for someone that's opioid naive if I feel like they really need something stronger than ibuprofen, Tylenol, et cetera.
Dr. Reams, I do see you shared a resource. I was wondering if you could unmute, perhaps elaborate on it, but also introduce yourself. Dr. Reams is part of our hub team, and we're happy he's here.
Yeah, John Williams, internal medicine doctor, addiction specialist here in Austin at Community Care in UT Dell. I thought the discussion just now was more than I could have added. Just for resources sake, I put that in the chat. It's pretty extensive. There's a nice, for patients transitioning, there's a really nice sort of OME, MME estimate to Butrans or sublingual bup dose that we've used for some of our clinical guidance we've developed internally here. So just wanted to throw out that VA resource. Great discussion.
Thanks, Dr. Weems. Dr. Miramontes, could you unmute and elaborate on that? Is that for a future topic or is that in relation to this topic?
No,
I'm
I
sorry.
noticed. I wonder if our lecturer could discuss the relative bioavailability of the sublingual tabs versus the strips. My patients don't do really well with the tabs, and it seems like the insurance companies really want to push you to switching your prescription from strips to tabs because of cost. Maybe you could comment on that.
Thanks, Dr. Montes. Yeah, I've certainly had that experience as well. I have had some patients that do fine with the tablets. A lot of patients that feel like they're not nearly as effective. So I generally, if I'm converting, the most of my experience with this is converting from films to tablets for cost reasons, like you just mentioned. And almost 100% of the time, I would say it's about 80 to 90% of the time, we end up needing to increase the dose. And that dose increase is generally about 20% on average. So that's kind of a rough estimate, but and sometimes more. But a person on 4 milligrams of the films might require 6 milligrams of tablets. Someone on 16 milligrams of films might require 20 milligrams or higher, 24 milligrams of the tablets. And I don't know, quite honestly, Dr. Miramontes, if it's a bioavailability thing or if it's an issue with the amount of medication dissolving adequately. That's my sense of things, is that it just takes longer for the tablets to dissolve, and they may not get as much of the medication through the tablets as they do with the films. So I try to counsel people that don't have another option just to give it plenty of time for those tablets to dissolve.
Yeah, I've noticed I've had to do, instead of BID dosing, I'd have to do TID dosing with the same dose. So it's kind of stupid because the insurance company is now buying a third more pill. You're, but that's my experience is if they're BID for 8 milligrams, they need to flip to TID in order to get the same effect. I tend to I tell them, if you can afford it, pay the extra couple bucks for the strips.
Yeah, unfortunately, that's what it comes down to a lot of times, is what our patients have access to, and doing our best with that.
Thank you all. Any other questions from our audience or comments? I do see that Rini gave some great feedback on wanting a session on a prescribing bupe for pain for patients, including combining with other opioids. And our coordinator for this echo, Jasmine, she responded that our next echo on the 28th of August will be on pain management and perioperative opioid use disorder care, presented by Blair Walker. So be sure to mark your calendars for that. And also, we always welcome feedback like this in our session and also in our post-session survey. Um, but any last minute questions before we move on to announcements? If you all think of anything, feel free to drop those questions in the chat. Thank you, Dr. Bond, for your didactic presentation. At this time, we'll move over to announcements for today. Karen, if you could please share those slides. Thank you so much. To claim your CME credits for today, please ensure you have a registered account and then text attend 10100-245 to 844-502-1338 no later than midnight tonight. When you complete the post-session surveys, you are helping us shape these sessions to fit your needs and to focus on the topics you all would like to learn from. This series was created for you all, and your feedback truly matters, and we do take it into account when we plan our curriculum. Your ideas, experiences, and suggestions help plan these future sessions, and they give us insight on what we should cover, how you want the content delivered, and the kind of support we can offer you all. Please do take a moment to complete the post-session survey. We are listening and we do look forward to reading your feedback. Next slide, please. CSTAT offers you all the opportunity to present any challenge your organization is encountering and to receive feedback from our hub of experts and broader learning community. There's no need to prepare a formal presentation as we do have this really great form that is fillable and easy to use, and that is designed to assist you in your case presentation. If you're interested in presenting a case, please email us at cstat@utesca.edu. Thank you. Next slide. And if you would like to participate in a mentorship program for the Texas Public Health District Region 8, we invite you to use the RedCap link that is listed at the bottom of the slide. Next slide, please. Join us on Tuesday, August 26th for a Texas Sus session developed directly in response to needs expressed by our learning community after the catastrophic flooding the Hill Country faced in Texas. Together, we'll explore strategies for navigating disaster recovery and delivering substance use and other behavioral health services that meet evolving community needs. To register for this session, please visit texsus.org/sessions. Next slide, please. And finally, please do join us for our next session presented by Dr. Blair Walker on August 28th. She will be presenting on pain management and perioperative opioid use disorder. Thanks so much, Karen. And now we will go ahead and move on to the case presentation for today. Dr. Bone, once Karen shares the case form, please walk us through it.
So is the case form visible? Yeah, okay. So the case for today is just a 54-year-old male, Hispanic male, and yeah, the questions that I would like help with, what could be contributing to this patient's fatigue? Also curious if people have advice on how to potentially counsel this patient regarding stress management and his family dynamic. And lastly, curious how other providers approach chronic pain through virtual visits. So this gentleman had opioid use disorder, started 15 years ago, began with prescription pain medication for back pain, and then just got out of control. Ended up impacting his ability to work, to take care of his family, and also his relationship with his wife was strained by it. He's been on buprenorphine for 3 years. He's on 16 milligrams daily. And in general, those things have gotten better. He's still married, he's employed. He's currently living with his wife and his 2 adult children. He doesn't have a comorbid substance use disorder, it's just opioid use disorder. And yeah, he's taking medication as prescribed. Um, he does report significant childhood trauma and asked to speak with a counselor regarding that, but hasn't been interested in really diving into that with me. But yeah, he is engaged in counseling services for that. Um, has not had any non-fatal overdoses, no history of injection drug use, but he does have naloxone in the home. He has good transportation, so he does come to the office. He's been here once, but mostly he's unable to come to the office because of work. Like I mentioned, lives with 2 adult children and feels a lot of financial stress and emotional stress caring for them, and also said he feels bottled up. There's nowhere to go. So currently employed, like I mentioned, but he's had 4 jobs in the past 6 months, all in construction, and a lot of the job turnover has been related to just his energy level to get out of bed and go to work. It's also causing that low energy is also causing strain on his relationship with his wife. When he's not working, all he wants to do is sleep. So my thought was, could this be depression? So he's on Wellbutrin, 300 milligrams daily. In addition to that, he's on amlodipine, 10 milligrams daily for hypertension, and ibuprofen, Tylenol for chronic pain, in addition to the buprenorphine 16 milligrams daily. He does have a history of COVID and was diagnosed with long COVID syndrome. And that was about a year ago. So yeah. So as far as treatment plans, so from an OUD standpoint, his condition stable on buprenorphine naloxone. He doesn't have any cravings, hasn't had any illicit opioid use in more than 2 years, taking medications prescribed. And yeah, he's on Tylenol, ibuprofen for his chronic pain. I'd say no significant pain interference in that he's able to complete ADLs and also job duties. I thought his depression may be contributing to fatigue, so I started him on Wellbutrin 75, but the counselor have titrated that up to 300 milligrams, and that fatigue is still really persisted, and that's his primary concern. So yeah, so those are my questions. Thoughts on other possibilities, what may be contributing to this patient's just profound fatigue, and then any, evaluation, potential treatment interventions for that. And then also the family dynamic, part of me wonders if he's just trying to avoid his family. Like I said, he's living with his two adult children, feels like there's nowhere to go. Also wonder, and so if kind of an avoidance may be contributing to sleep. And then that third question was around virtual management of chronic pain. Curious how providers approach that.
Thank you, Dr. Bone. So I already see some questions coming in from our hub members in terms of sleep, and has he been evaluated for sleep apnea? What is his sleep like?
Yeah, so he sleeps, what is his sleep like? So he does snore. He is being worked up for sleep apnea by his PCP. So that evaluation is pending.
And I was curious about other medical workup of fatigue that's been done. Particularly, he's in his, I think, 40s or 50s. So has there been like a low T workup, thyroid, any other kind of medical workup for fatigue that would rule out that and get us more focused on the depression? Or is there something simultaneously going on?
Yes, so we initiated a base workup. So we did a CBC that was normal. So he doesn't have anemia. A TSH was normal. Doesn't have hypothyroidism. His testosterone level was 83. And yeah, normal is 300 or above. So
Yeah.
yeah.
Yeah. So that might be one avenue. I don't know if it's the whole thing, but certainly maybe adjusting that along with other things. So this really ties in nicely to your earlier work. Imagine that. Thank you.
Yeah.
Other thoughts from the group? And so I'm seeing change in depression, medication, and social support.
I also had a
Oh,
question considering what I've noticed is that some people do get quite tired with the buprenorphine. So was there any thought with respect to maybe adjusting his dose? But ironically, some of my patients, they're tired on 2, but they feel great on 3 or 4. So I'm just curious whether any adjustments to his buprenorphine have been considered.
Yeah, that's a great question. So particularly in the stabilization phase, I really titrate based on energy level, and I sort of tell people you have a certain opioid requirement, and to meet your, and so we titrate to sort of meet that, to get the dopamine levels appropriate so that they have enough energy to get through the day. So yeah, he's sort of stable at this point. From that, and so I think what I do encounter though is people sort of often say, well, it's not working for me anymore. It's stopped working, where people sort of think they develop tolerance to it, which you don't really see with buprenorphine, right? So yes, that was thought about in someone that's stable. I think less about titrating up or titrating down, but early on, I certainly consider it. The longer you are on an opioid, the higher risk you do have of developing a testosterone deficiency. And again, buprenorphine, lower likelihood of contributing to this, and some studies suggest that can't occur, but it certainly does exist in our patients.
Also, have you checked the sex-binding globulin? And also, when was this testosterone measured?
Yeah, it was a morning testosterone study. So if you so you need to get it before 10 a.m. There was just an initial testosterone level that was done, and so he still has sort of the subsequent workup pending.
And around his doses, is his pain well controlled with that? Because I know he started the opiates, I'm presuming for the pain issue, and I was just curious about that and his dosing in terms of it seems like, although I'm reading into the case for that, is that he's on twice daily dosing, which is not sometimes ideal for pain. He may be getting some wear off of the analgesic effect, and if what's going on with that with him, because that can cause fatigue too, just dealing with pain.
Yeah, sort of like a lack of desire to get out of bed because it's difficult. It's right on a lot of levels, and so that's a great thought. I haven't considered breaking up his dose more than that. Part of the job issues it's energy to get out of bed, and then he also has had a tough time finding the right fit for a job that he can complete comfortably. So he's been able to kind of do these jobs where it's been kind of miserable for him. So I think that's definitely a possibility to improve quality of life and pain control with breaking that dose up more throughout the day.
Yeah. And that might argue increasing the dose if breaking it up isn't enough. Maybe he needs a higher dose, not for his opiate use disorder, for maybe his underlying chronic pain issues are worsening now that he's getting a little bit older, and that might be needful.
So it was mentioned in the chat that a change in depression medication might be helpful here as well. And one thought is the increase in perhaps the bupropion from 300 milligrams to a max dose of 450. Some people are able to tolerate that and find that that can be helpful as well. SNRIs like duloxetine, known as Cymbalta, or levomilnacipran, which is Fetzima, have also been shown to be effective for treating that comorbid depression as well as pain. And so, rather than switching him from bupropion, perhaps adding an SNRI could be helpful for him in this case too.
Yeah, thanks. Thanks so much for that, Dr. Shorter. I do worry, and I'd love your thoughts on this. I do worry a little bit about super high dose bupe, I guess max dose bupe, in people 50 and older, because you do have a change in your pacemaker, the number of pacemaker cells that you have right around age 50. And we see a big uptick in arrhythmias for people that are on stimulants after that time period. I think about, and again, I'd love to hear your thoughts on this. I think about Wellbutrin kind of as, a stimulant. It increases dopamine levels, increases norepinephrine, similar to, Ritalin would, just at lower concentration. But I worry about the higher dose concentrations of bupe. Do you
Yeah,
have that?
Yeah, all legitimate. I mean, I think on the psychiatric side, because of the complexity of psychiatric care, psychiatric comorbidity that we're seeing, my sense is over the last several years, especially, we are pushing people to high doses, higher doses and maximum doses of medication, and also using them in combination. And so there, I guess, is kind of a question about whether or not you would like to add another medication while keeping the bupropion and sort of weighing out the risks and benefits of that. There is, of course, it's not that there's no side effects with the potential addition of something like duloxetine. We would be adding a medication that would perhaps have a sexual side effect, and we haven't necessarily talked about sexual side effects for this guy, but given the low T, maybe that's something that's also in play. And so perhaps you were trying to balance the addition of something like an SNRI, which could worsen that, while also trying to maintain him on bupropion, which has a lower risk of sexual side effects. So the complexity of his case does kind of ratchet up the more medications that we think about adding, as well as how we might max out the dose of it. But going for the low T, since it's kind of like the sort of and essentially like the low hanging fruit here, that might be a great starting point. And with optimization of that, if he finds that depression is improved, then maybe you don't have to go on and add another medication or even max out the bupropion at all.
Yeah, thanks for that. I think that makes a lot of sense. It could be an intervention that helps with energy level, with mood, It doesn't seem to improve chronic pain a whole lot. That we haven't seen a lot of benefits there, but it may improve pain interference, just someone's ability to sort of get through the day. I feel like someone said to me at some point, there's a huge difference in someone that has chronic pain who has depression versus someone who has chronic pain that is not depressed. Just what that looks like, what that feels like, what that sounds like, and their quality of life. And so I feel like if we can help on the mood and energy standpoint, how he feels about pain and what that actually looks like, that could change as well. I
I
am
have a
curious. So
question.
sorry.
So I generally have found that just, in my primary care patients, I'm not a psychiatrist, but I do treat quite a bit of depression. Bupropion monotherapy is not very effective for people who have pretty significant depressive symptoms. I'm curious to see whether others have seen this too. I mean, I'm much more inclined to give sertraline or um, Lexapro, escitalopram. Um, so I'm curious whether others have seen this. I think that may be a reason for that. And I also don't find that it works that well for someone like him who has a lot of fatigue. I see it more for like sexual function and that kind of thing, or people that they're just adamant that they don't want to take something like mirtazapine because of the weight gain.
Yeah, appreciate that. I have a question, just kind of piggyback off it. An SNRI or TCA, something that has some effect on pain would be ideal, right? That also helps with mood. I guess I'm curious. I have a lot of patients that recognize there's variability here, but they seem to be more sedated, or they find Cymbalta, for example, causes more sedation. Um, do you, do you find that, Dr. Shorter, with your patients, or curious experience from others, if they find certain SNRIs are more activating and less
Yeah.
sedating than others?
So not necessarily. I mean, a lot of times what happens for someone that might have been prescribed an SNRI is that they have already tried 1 to 2 SSRIs and maybe not been successful on that class of medication, and then we switch to an SNRI. Or if they present and there's a significant component of anxiety that is comorbid with the depression, you might start with an SNRI as well. So much of it is individualized to the person that you're working with. So there may be times when Wellbutrin or bupropion wouldn't necessarily be your first go-to medication. However, the patient is insistent upon taking something that is not at risk for weight gain and that will not impact sexual functioning. And so you might go in that direction because it's what the patient is most willing to take at that time. And of course, you sort of give the multiple caveats. Listen, if we don't get much of a improvement in your depressive symptoms, or you're anxious and it does nothing for your anxiety, then at that time, maybe 6 to 8 weeks out, we would think about pivoting or adding something else. And so there's really oftentimes a lot of negotiation that takes place. People can have a lot of preconceived ideas and notions about what medications will or will not do for them. And that can be a major determining factor in what does and doesn't get started. I love mirtazapine. I think it's a great medication for a lot of different reasons, and people are often willing to tell me to my face how much they're now, like they're never taking this medicine because they've heard that it causes weight gain and they don't want to. And at that point, it's like, okay, well, I understand that. Then let's try to figure out some alternative that maybe might work a little bit better for you here. So there's a lot of conversation and sometimes negotiation that takes place, and we really just ultimately try to meet people where they are and what they're most willing to do.
A question that, it's occurred to me that long COVID syndrome could be contributing to this. And I'm not an expert by any means in long COVID, but is anyone aware of interventions that are useful for energy, cognition, et cetera, for folks that have had COVID and have had persistence of symptoms thereafter?
I This is something that I keep track of because I have several patients with long COVID syndrome, and there have been some studies on things like certain probiotics. The studies have a lot of issues, but there are some drugs in the pipeline, but I don't think that there's anything that's well, certainly there's nothing FDA approved. And then even beyond that, I haven't really seen anything other than if the patient just happens to have a thyroid issue or maybe the COVID affected their heart, optimizing the cardiac care. But really, that's a really vexing problem. I don't think there is anything that works well. And then I also wanted to follow up on your comment about the Cymbalta, duloxetine. I know that some people can take, 70, 60, 70 milligrams or more and not complain of fatigue. But I would say a good 25 to 30%, maybe even 40% of my patients, they cannot tolerate it because it just slows their thinking down too much, or they become extremely fatigued. I've had to take patients down from 30 to 20 because they have they need the medicine for the pain, but they just cannot. They say, look, I have no energy, and adjusting the medicine has helped. But I know I know I've brought this up before, and there's been an argument about it, but I'm really curious about that, whether other people have seen the same thing, or am I just have an aberrant patient panel?
Yeah, and I wanted to highlight a few things that have come up in chat. One in particular around behavioral therapies and counseling therapies for addressing the chronic pain, including the CBT and ACT, and getting this patient also engaged with a supportive peer group, perhaps, since they're feeling trapped and like they have, quote unquote, nowhere to go. And I don't know if those have been explored. I just wanted to highlight that in chat. There's an interesting mention of a resource, I'm presuming in the Austin area, Rachel, that there's a long COVID clinic up there. I don't know if they offer virtual services. And then Dr. Ramesh has found an interesting article on very low dose naltrexone helping with long COVID symptoms, although maybe somewhat contraindicated in someone on bupe. So just really interesting discussion in chat if anyone wants to pick up on those threads. Also seeing just come up, thank you, Penny, nutrition, activities outside of the home. What are they doing? What is this person doing for fun? And what's their external support, if anything? And of course, peer support.
Yeah, so that's part of the problem is he doesn't feel like he has the energy to get out of the house and enjoy time when he's not working, and that's creating strain with his primary support, his wife, who is frustrated by his lack of energy. He's getting up and going to work and really feeling maxed out with that because he does, his two adult children are living with him. So he feels just a lot of financial pressure to keep the whole family afloat right now. And he's simultaneously really frustrated by that. He's, they're living in a bedroom in the living room. And so, like you said, he feels bottled up. There's nowhere to go. And so part of me wonders if he feels like the bedroom is the only place where he can, have a moment to unwind. And if that's partly contributing to some of this, if he feels just sort of stuck. And I also wonder too if financial pressure and strain is leading to some of his isolation. And obviously the low T is there, but there's all these other dynamics too. And so yeah, and I'm not exactly sure how to provide counseling around that family dynamic. That seems really challenging. It's a chronic stressor. And I don't know if there are counselors on this call that have any thoughts on that.
Any behaviorist therapist wanting to jump in and mute? I see an offer for couples counseling might be helpful. And then a mention about uric acid levels and changes in uric acid levels with long COVID and if that's been looked at.
Yeah, we haven't done an inflammatory
Yeah.
workup, which I think is a great thought.
Have you thought about
Um,
inviting the spouse?
I'm sorry. I do a lot of inflammatory markers and uric acid on my patients. And what I'm seeing is there is a lot of association between the high uric acid and inflammatory markers, as well as the cardiac disease, high blood pressure, high cholesterol, insulin resistance, and all those things. So, and also it has some association with the brain inflammation. So, just I throw that out there, and my patients get better.
Thank you for sharing that insight, Tessie. Dr. Luckner, you had unmuted. Were you going to add a comment or a thought on that?
Um, uh, sorry. I'll leave it alone for now.
Sorry to put you on the spot. And Dr. Dostal, could you unmute and briefly elaborate on that, please, on your comment?
Hello, can you hear me?
Yes, we can hear you.
Yes, so this is something that's tested on the internal medicine boards, right? I took them within the last 2 years, so I remember all too well. But the association between obstructive sleep apnea and low testosterone, right? And if you diagnose someone with low testosterone and you replace that testosterone, you can make the obstructive sleep apnea worse, right? And so one of the things that I do some testosterone replacement in my primary care and in my primary care sub clinic, but I definitely recommend everyone, regardless of their body habitat, habit, um, habitus, to get a sleep study. And I think we need more data. We just need to study this better. And it would be great to know. I mean, I would suspect, at 8 milligrams TID for some time now, the patient might have some central sleep apnea. I'm not sure how badly, but I think that could be possible. I had a patient on that dose that had a very slight build and low BMI that had significant central sleep apnea. So that wouldn't surprise me. But I forgot from the vignette also if this person was normal weight or overweight or either way.
Yeah, thanks so much. I didn't mention his body habitus. Yeah, he is overweight. So his BMI 36, and yeah, and hypertension. Yeah.
Yeah, THC use?
No other substance use.
Cool.
Yeah, great question.
That's another thing that we see a lot, right? Is low testosterone with chronic THC use. But yeah, just thanks, Dr. Brown.
Sure. And alcohol as well, which could contribute to all the symptomatology, but yeah, no alcohol use. Although we haven't done a PEth test, and we probably should.
Thank you, Dr. Dostal. And thank you all for this wonderful discussion today, for your resources, your insights, and shared experiences as well. Dr. Kowalczyk, I pass the mic to you for a summary of today's case and recommendations for Dr. Bone.
Yeah, so we started out the hour together exploring side effects of mood, and then we dove into a case and exploring a patient on longer term mood that's still dealing with significant depression and fatigue, along with their chronic pain, which seems to be managed by the mood. Definitely a low T issue and possibly a sleep issue with sleep apnea. But additional thoughts from our panelists and also from our hub members included exploring perhaps getting couples therapy and other behavioral therapies involved, adding on an SNRI or an SSRI, and or maxing out the bupropion the patient is already on. And then a rich discussion of other factors related to long COVID that might be contributing, and leading to hopefully something helpful for this patient to move forward. I'm probably forgetting a lot of things in there because this was a very complex case and really got us through a lot of discussion. I also wanted to, acknowledge the other big side effects that were talked about beside hypogonadism, constipation, probably the most common, and that to take that seriously and ask early and often about that side effect. It doesn't tend to tolerate out. And just thank everyone for wonderful participation today. Great case, and we're looking forward to our next session together.
I echo those sentiments. Thank you so much, Dr. Kowalczyk. Thank you, Dr. Bone, for the double duty of didactic and case presentation. Thank you to everyone that shared insights today and for those that attended. As a reminder, to claim your CME credit, you must text by midnight tonight. Text attend 101-00-245 to 844-502-1338. And also another reminder, please complete that post-session feedback survey using the link that Karen has shared in the chat. Have a wonderful rest of your week, everyone. We will see you all at our next session. Thank you. Bye-bye.